So welcome back everybody, and we're going to go on now to the question and answer session. Hello, my name is Melanie Clements and I'm the Interim Medical Director for the East Anglia Area team. And I've spent a number of weeks in the beginnings of this role outside my comfort zone, but as a consultant paediatrician I have to start by telling you today I am in my comfort zone. And many of those things that people have talked about the extended hours working, consultants in the evening and at weekends, and even consultants on junior doctor rotas, I'm very familiar with, and I can help any of you with the job planning process with that. So I think we have to remember that we have already made a lot of progress in hospitals with our 7-day services. But before I hand over to the questions, I just wanted to tell you, though, that I know from my own experience of being there at weekends and in the night that hospitals can be a very lonely place. And I want to tell you about a 9-year-old boy who presented with a Burkitt's lymphoma. And his presentation I was reminded of by Celia because he presented with spinal cord compression. One of my colleagues, it was her first ever weekend on call, and she couldn't get an out-of-hours MRI and was a bit kind of absolutely surprised and shocked that we didn't offer urgent out-of-hours MRI. And hence there was a delay in trying to get him to the appropriate hospital because they didn't accept without an MRI. And so some of us in this room have been there many times. This boy has made a full recovery from his Burkitt's lymphoma. He has been cured, but he absolutely loves football. And he also not only had to cope with having a childhood cancer, but he spent a year in a wheelchair and was catheterised for a good 6 months. He's fully recovered, he's walking. His parents, who I meet every weekend in Waitrose and remind me of this story, they think it's positive, but I know his football skills are never going to be what they were. So I truly know that 7-day working does make a huge difference. And ward rounds on the paediatric ward, and we're very lucky in paediatrics because we have small numbers of patients, but our ward rounds, since we've been doing extended hours, have shortened and are really kind of blips in the day rather than half-day or whole-day events. So at that, I'm going to stop and hand over to the panel to answer some questions. And I really hope that you've all got some good questions for the panel. There are 2 roving microphones. So there's Tracy and Christine who've got the roving microphones. So if you want to put your hand up to ask the first question, and if you could please introduce yourself as well first. And then if you want to just put them open to the panel, we've got a question down the front here. Just here at the front, sorry. So please introduce yourself, and if it's for a particular person or just for the panel. Sorry, I forgot to introduce Shane Gordon, but he's reminded me by jumping off the stage. Shane Gordon is the Deputy Senate Chair, and he is the Accountable Officer for Essex CCG, so it's very good to have him on board. And since day one, he's been a real supporter of the Senate. Thank you.
Thank you very much. It's been a great listening to all of you with your varied experience and your input. My question is about the balancing the resources at the moment in the NHS and the prioritization. Are we focused on improving the 7-day services for emergency and urgent care, or are we going above board for everything?
Who would like to answer that one? Celia.
Shall I start off?
Thank you, Celia.
Okay. So, yes, prioritisation is important, and top of the list is patient safety. And then very closely behind that, in my own view, is patient experience, and obviously they're very closely aligned. What you can deliver locally, we know that we want to have a focus on the acute end to start with, because that is where we've seen the biggest concerns about the difference in mortality and the things around that. However, there are some organisations who, once they've put services in place to deal with the emergency and urgent work, actually it will be to their advantage, not just in terms of customer care, but also in terms of the economics, to actually run some routine services at weekends as well. So at this stage, we're not saying we want everyone to run every routine service 7 days a week. That would be a local decision. But it's surprising, once you've actually got the support services in, how many organisations actually think it's of value to do that. Once again, it's to do with the demand, what's required to support the work that's coming. We know that people are struggling to hit the 6-week goal for diagnostic tests. People are struggling to hit the 18-week goal for the referral to treatment pathway. And so many organisations, probably many represented in this room, are already doing weekend MRI lists for routines or weekend endoscopy lists for routines in order to deal with that. So the short answer is not, you don't have to do routines 7 days a week, but actually it may be a good idea.
Do you want to add to Bernard?
Yeah, I think clearly we are in very difficult financial times, and clearly we've got a significant pressure from demography, with more and more people living longer with more comorbid disease, which adds an additional pressure to the system. But what I didn't include in my slides, I have done some work looking at the cost effectiveness, for example, of consultant level input at weekends, and looking at analysis of cost per bed day. And you only have to reduce the length of stay of one patient by 1 day for a ward round, and you've covered your cost as a consultant. If you start to look at diagnostics, then the difference might be even greater. If a CT scan isn't done at the weekend and it's in that big pile for Monday morning, it might not even get done till Tuesday. It might not be reviewed by the senior clinician till Wednesday. A decision about the diagnosis and the management of that patient could have been made on the Sunday or the Saturday, so you could be making a massive impact on the outcome for the patient as well as on the cost of the patient care.
Sorry, yes, I'd just like to reinforce that really for diagnostics. I did speak about elective versus non-elective, and I think we're certainly aware that it is probably more cost effective for a lot of these diagnostics to be run over 7 days, particularly in big pathology laboratories. And as Bernard's just said, it avoids the Monday morning backlog, and it's about looking at that bigger picture, not just the cost of those individual diagnostics, but how does that improve the patient care and experience and actually improve the safety for all our patients, and in some ways for the staff as well, because if they're faced with 1,000 samples on a Monday morning, that's incredibly daunting.
Thank you. Simon Wood had his hand up in the middle there. Got lots of hands going up now. Good.
Thank you. Simon Wood from the Eastern Academic Health Science Network. I suppose just following on from that, and perhaps a question for Senior initially, I was really struck by the clinical standards you put up, but as I was sitting here, I was wondering about, so what about a similar set of clinical standards for the system as a whole? And thinking about the Better Care Fund, would that be a useful thing to develop, to then begin to focus more the discussions around what it is we're seeking to achieve through the Better Care Fund, and whether there's anything sort of going on about that at a national level, or whether you think maybe that's something that we should be looking to develop more locally.
Yeah, there's work going on at the moment to develop 7-day clinical standards for primary and community services. I'm not directly involved in that. I don't know if any other panel members can give you any idea of what's happening with that. One of the things that I've tried very hard to feed in that is relevant, though, is when we did some work similar to this in London a couple of years ago, one of the things we developed were inter-hospital transfer standards. And we did that with commissioners, providers, and with the ambulance service. And it was around not only getting that sick patient who needs to go to the specialist centre in there safely and quickly out of hours, but also getting them back from the specialist centre to the DGH quickly and appropriately in order to free up a space for another patient. But those standards are available on the London Health Programme website, and others have found them useful.
Shane.
I think it's a great question, actually, Simon. I'm really keen to see the developing evidence base for what bits of primary and community services really make a difference being available 7 days a week, because we know we've got 24-hour district nursing and 24-hour GP care, and just opening the doors of GP surgeries more hours doesn't seem to have made a difference to the demand at the hospital end. So it's got to be a bit more focused than just open longer hours. But the other component I think is really important is social care. So for me, part of the most difficult bit of urgent care at the moment is the flow through the hospital and the discharge end of the hospital. Monday is always a bad day because there's a whole backlog of people who haven't been moved on over Saturday and Sunday. And if we can crack that as part of this process of looking at 7 days, I think we'll make the whole system flow better and therefore be safer. And the input into doing that is a known quantity, it's doable.
Just to confirm, NHS England are developing primary care standards. They're still in the development and refinement stage, and I think they're coming out to consultation shortly on that. But we have in HEE been working very closely with them to look at what workforce models might fit against those standards. So more will come of that probably early in the new year.
Thank you. Next question, just here. Sorry.
Hello, my name is David Gaunt. I'm an emergency medicine consultant at Watford General Hospital. My question really starts, I suppose, to you, Patrick. When we look at 24-hour and 7-day services, obviously that does create issues for the staff that are going into those, are being put into more difficult rotas. And certainly for a specialty like emergency medicine, which is already difficult to recruit into, how do you encourage the consultants to take up posts such as these?
It's a good point. If you look at what we've been doing on emergency medicine, you're probably aware we've done a lot of work in the last 12 months with the College of Emergency Medicine, and actually the emergency medicine fill rate, which was less than 50% last year, we've actually had a 33% increase in applications, which meant that we've got, 100 and something extra EM doctors in training, more than we expected. So from the trainees' point of view, number one, the specialty is still attractive. The feedback from the trainees recognise A&E is still not the best environment and needs work doing. I think NHS employers are working with us to work with the college to say, right, what can we do to get employers to support those consultants over the next few years until we get the rest of the ED environment more stable. So we are pushing the alternative workforce, no surprise. So we are pushing physician associates, we are pushing pharmacists in the ED, and we are pushing advanced clinical practitioners, because it's not just about doctors, it's around how can we build the clinical team and how can trusts invest in that clinical team. And I think we've still got a 2-year window before we're going to get to anywhere near what I would call stability, and therefore it's what do we do in that next 2 years to keep people like yourself in the profession and demonstrating there's still hope to get through, because at the end of the day, workforce takes time to develop.
Just while we're waiting for this gentleman to talk, I'm really pleased to hear that, because having done peer review both nationally and across the east of England, it's the emergency physicians that I have the most sympathy for and already doing the heroics and underfilled posts. So that's good to hear. Thank you.
And I would stress it's not ED is one, but the other one we're worried about is the medical role of the medical registrar and how we support the registrar at night, because at the moment a lot of hospitals are leaving those individuals quite isolated as part of the hospital at night team, and that's not acceptable, and there are ways in which we can support them more.
Thank you. This gentleman here.
Hello there. My name's Trevor Fernandez. I'm a patient with a long-term condition. I'm also involved with a number of patient groups. I'd like to first of all congratulate you all on really good talks. I especially like Fiona because I know her.
We all like Fiona.
I have a question for you, Patrick, on workforce planning. I was involved in the early days, almost 2 years ago now, with a care review, and since then I've been involved as a lay assessor for CQC. One of the things that I've come across quite a lot was the use of agency staff, and in some trusts they worked well, and in some they didn't. And when you talk to these people, you start to get a clue of why they didn't work well. Coming on to 7-day working and workforce planning, is there going to be a potential to use agency staff? And what will that do to the quality, to the outcomes?
From my perspective on the answer, HE will have something wrong if we're still so reliant on agency. But I think we have to be real. We haven't got enough workforce in the places we need them, and particularly some of the really challenged geographies, of which part of the east of England has. You are still going to be reliant on agency until we can build the new workforce. And I would argue that the workforce needs to be fit for the geography that you're at and for what the patients require. And for some geographies, you are never going to be able to build the workforce that you may require, and therefore looking at alternatives so that you're not reliant on agency staff is the way forward. But that has to come from a local geography deciding what it requires.
Anybody else want to? No? Okay, so next question. It's the back just over there. Lady with the blue scarf.
Thank you. Dr. Sarah Dalton, I wanted to give the question of Dr. Fiona Kerry to the Speaker for Health Education England. What are you doing in Health Education England to prevent a junior doctor who, let's face it, is a graduate from failing to pick up the phone to the consultant? How can we overcome this perceived repressive, how consultants are perceived, and that lack of communication? Because if we can't overcome that at a basic level, we can't do anything else we've discussed. I think it might be an easy question for the panel to answer. Thanks.
I think the issue of hierarchies in hospitals is going to be a really big issue to overcome, because I think in the 21st century it's really weird. It's really weird to sit in a hospital bed and have conversations with able, well-qualified, really knowledgeable expert staff about all sorts of aspects of your care. And for that to be a really useful discussion, actually until a consultant arrives and everybody zips up and doesn't speak unless they're spoken to. I was really surprised to come across this. I worked at the OU for years. Regardless of what your opinion is of the Pro-Vice Chancellors and the VCs, when you met them in a corridor, you spoke to them, you used their first names, you could have input. But actually, it was kind of frightening that in a hospital bed, a consultant arrives and people seem intimidated to speak. 21st century, really? So I don't think this happens everywhere, and I know it doesn't happen everywhere, but it still does happen to some extent, and I think that's just really worrying. I acknowledge the expertise and the years of experience and so on, but it seems silly, really, for that to be the situation.
I think there are some examples that have demonstrated that you can break down some of those communication barriers, and the WHO checklist is one of them, which has been shown to break down some of the hierarchical barriers in the surgical environment. And I think handover is another one. If the consultant is actually present and the junior doctor actually sees the consultant and maybe even discusses some of the patients before they go. But in fact, this is one of the topics that we were discussing at the launch of the Patient Safety Collaborative just the other week, which looking at leadership throughout organisations, and there hasn't been much focus on ward rounds and communication interaction between patient, junior doctors, nurses, etc. And I think this is a key area. If we can, and through that process, through leadership development, encourage juniors to feel able to discuss concerns, and other members of staff and patients, then maybe we can move in the right direction and break down some of those barriers.
I have to say the patients aren't intimidated in the same way.
Can I ask a question back of the audience in relation to this, because it may be different culturally in different parts of the country? For those of you who do work in acute hospitals, do consultants introduce themselves to inpatients by their first name or as Dr. So-and-so or Mr. So-and-so, and do the other staff refer to the consultant as Dr. So-and-so or Mr. So-and-so?
Celia, you've stolen my question. I was going to do that exact same thing, but that's good because I think we know what we do.
Can I answer? As a junior doctor myself, I'm an obs and gynae trainee at the Norfolk and Norwich Hospital. I think some specialties and some hospitals are doing a very good job of breaking down barriers. We certainly are all on first name terms and we use first names with patients. I think it makes a huge difference, and across teams, not just doctor to doctor. I think on the particular example you gave, it's not just the lack of the doctor being reluctant to contact a consultant. I think something's gone wrong in the weekday planning when there is a team there, that there wasn't something in the notes that said that if the patient is well, they can be discharged. Because then the junior doctor wouldn't be feeling they were out of their comfort zone if they sent the patient home.
I hope that where we work, that people do call us by our first name. Sometimes it takes a long time to break those barriers down, and there are some particular doctors that has taken me a year or two to get them to call me by my first name. But I certainly know in my organisation we've promoted that. And I think the other thing is, once you're working alongside them, once you're there in the evenings, once you're there, we'll be working with SHOs at one point without any registrars, you break down some of those barriers and start to change the culture, but it can take a long time. So moving on to the next question, the gentleman at the back near the door.
My name's Frank Stafford, I'm a consultant. And I was actually going to respond a little bit to that statement and the notions that are being put around that consultants are unapproachable and distant and not present at weekends. I'm actually a head and neck surgeon at Brimfield Hospital. I'm also co-chairman of the head and neck CRG nationally, and I'm the Senate representative for head and neck as a way of introduction. Actually, I'm 60, and my SHOs call me Mr. Stafford, but that's because they're in their 20s. Some of the registrars will call me Frank, especially the ones I've known for a few years, but frankly, I think that there are some social norms here. Now, I think from the stories I've heard this morning that some of you have met some pretty weird consultants, because this is just not my experience. And one of the things that I'm a little disappointed about coming to this meeting was that I thought we were going to talk about 7-day working, but we're not. We're talking about 7-day emergency services, which we're supposed to have already, and 7-day urgent care, which we're supposed to have already. And this isn't about 7-day working. I worked in the States and in the Middle East as well. One of the things about those cultures is that hospitals stay open 7 days a week and they work 7 days a week. And that's because the patients are all earners. When you get patients in, they bring money. Unfortunately, in our NHS culture, I get the impression that most patients are seen as a drain on resources. And that's just because of the way it's developed. And we have to change that if we're going to change anything. Unfortunately, the recent reorganisations of the NHS have done nothing to address that problem. There's so many things I'd like to say about things that have been said this morning, but I think that the standards that you mentioned earlier were very good, and certainly the availability of consultants needs to be increased, and partly that's because the senior junior doctors are now no longer senior junior doctors. We don't have senior registrars anymore. When I was a senior registrar, you ran the ward, and I'd already done about 6 or 7 years of ENT before I got anywhere near that. They've finished their training after 6 years in ENT now. So that may be the reason why some juniors are a little less able to manage problems effectively. But that's not the point. Currently, consultants are still not remunerated for being in at weekends or on call. We get a minimal extra bit on your pay slip because we're not meant to be in very often. If you look at the way that the UMTs are structured for on call, we only get about a tenth of what we should be getting for being in there all day. In Broomfield, we do run a 24/7 consultant service, so there's a consultant in Saturdays and Sundays for ENT and head and neck. But we're not really supposed to be there. It's meant to be the junior doctors who are running the wards at weekends. And unless the hospitals are going to actually give us the incentive to be there all the time, why should we? I mean, I'd work at weekends, for sure. But anyway, perhaps you could address some of those issues I've brought up. But believe me, consultants are approachable. It doesn't matter whether you call them by their first name or not. I think it would be inappropriate on a ward round for the SHOs to be calling me Frank in front of patients.
Thank you, Frank. Sorry. I mean, I think we are paid well compared with our nursing colleagues, and I actually think our nursing colleagues work on a 7-day week basis. We do get an uplift in our PA payments. It might not be as much as we think, but it's the culture that we need to change, that it's a 7-day service, so that weekends are looked at differently. So I don't know if anyone else wants to add any comments to that.
Yeah, I mean, firstly, I would agree that there's lots of excellence in terms of consultants and their communication skills and junior doctors and their communication skills and throughout the workforce. Yet we know that isn't always the case. From my own trust as medical director, lots of our SUIs, or what we call RIG cases, rapid investigation group cases, when we look at the root cause analysis, nearly always there's a failure to escalate. And certainly one of the barriers of that is somewhere in the system at some time has felt nervous or unwilling to contact someone higher up. So even if there's excellence most of the time, you don't need a very high percentage hit rate before you might be running a risk of major adverse outcomes. The second thing is today's event is about 7-day services, and overall, and you look at the workshops as well as through before lunch and after lunch, there will be a broader breadth of looking at not just emergency services. But I wouldn't make a huge apology for saying that that's been quite a big part of today's talk. Those figures in terms of mortality relate to the last couple of years. They don't relate to 10 years ago. There is still an issue. And even if some trusts provide excellent emergency care, there certainly are shortcomings in most, if not all, trusts in the UK. So I don't apologise for that, I'm afraid.
Thank you.
I would agree with that. In terms of the comparison with America, I wouldn't disagree. It would be great if we could have all our hospitals running 7 days a week, both for emergency elective. We do not have the financial resources in the UK to back that compared to the American system. However, we still sit as number one in the Commonwealth Fund comparators of, healthcare systems. So I don't think we should put ourselves down too much. Until we build that workforce capacity to be able to truly work a full 7 days, both emergency and elective, we're not going to get there. And as a country at the moment, we can't afford to do that. So I have to say, we have to get our basics right on making sure that we really do have an effective primary care service that's 7 days a week, and an effective and urgent and emergency care service that's 7 days a week. And until we can build the workforce capacity just to get that right, I don't think we can even start looking at the elective stuff apart from within the private sector.
Okay, so next question, gentleman just here.
Hi, my name is Asif. I'm a psychiatrist and member of the The buzzword at the moment is let's just thinking ahead, because we really need to think ahead after the election. And the buzzword is integrated working, which means health and social care working together. I haven't heard a lot about integrated working, because that's the challenge, because how do you bring social care with different language, different system, how do you integrate it with health? The way things are going is a lot of money is being transferred over to social care at the moment from the health budget, but what would that look like? And I just wanted to get a view around education, bringing those people, developing a common language, I think is the first one. We call it health and social care needs assessment. We call it review. They call it we call it service user. Sorry, we call it patient. Call patient patients. They call them service user. The language is very different. How would that look like in future after the election?
Shane.
I think you're absolutely right to highlight this as a an area that needs further development. We've had things like the single assessment process, which is supposed to cover nursing and social care assessment for 15 years now, and we still see that process not working very slickly. And I think a big part of that is the training in silos of the workforce that own the different arms of those assessments. So people are people with a range of needs, but we train our staff to deal with nursing or social care, for example. And I'd be very interested to hear from Patrick about what the thinking is on staff trained in competencies across that spectrum of needs, because we're not going to crack, certainly in my area, we're not going to crack the challenges that poses us if we're still sending 2 members of staff to each person to deal with those needs separately. That's intrinsically inefficient.
There's an easy one for me to solve for you. It's an issue. We have started a conversation with the social care and the local government association around this, but it's not a quick, easy fix because all the local authorities do things differently. You know, the range of skills that the local authorities have and social work mix and everything else is so different. I agree with you about the language, but we can fix that just by having the conversation, to be honest, and that can be done through a local geography. I certainly did that with St George's and Wandsworth in terms of getting local people working together in local teams. I don't think we have a quick fix for it, to be honest, in HEE, but we have started the conversation, and actually I'd put it back to the audience. We'd welcome your views if you think there are some easy fixes on this one.
We've got time for one last burning question. So who wants to ask the last question? That man's hand there. He needs a microphone now, just down here.
Hi, I'm Dan Doherty. I'm a physiotherapist and Director of Commissioning from NHS Mid-Essex. I think the arguments around the move towards 7-day working have been well made, and I think they're quite compelling. My question's, I suppose, a fairly obvious one, but particularly for nursing workforce, AHP workforce, consultant workforce, we've heard a lot about the need to increase that workforce. There are a number of issues in doing that, our duty of care to our employees. One that springs to mind to me as a father of 2 young kids is childcare, and I know for a lot of nurses, a lot of AHPs, the move to 7-day working, they dread because, unfortunately, at the moment, education isn't 7 days, and therefore parents will need to find a mechanism to allow them to move towards this. Likewise, a lot of social activities, people who are involved in sport, people who are involved in kind of religious, cultural events, all of those things tend to happen at weekends. I appreciate it'd be a rotated system, it wouldn't be all the time, but the planning would need to be meticulous for parents. It's hard enough as it is on a Monday to Friday basis, but if you throw in the odd weekends as well. So I'd be interested if anyone had any comments as to how organisations that have managed to achieve this have managed to support their staff to make them feel enabled to do what, you know, to achieve what is a very admirable objective.
Well, this is where I'm glad that I'm facilitating rather than answering the questions, because that's a hard but very valid question. So,
hi, can I just comment on that? I think, yeah, it's a very good point, and I think it's something that people raise immediately when we talk about. And can I just make a comment? 7-day services rather than 7-day working, because we're not expecting people to work over 7 days. In my own service, when we looked at that, we went out to consultation, and actually the staff were really positive about it because they could see for them there were some advantages in perhaps having a day off in the week when they could actually take their children to the doctors or actually do their shopping on a day when it was less busy, and then they could spend the time with their family on either a Saturday or a Sunday, whichever one they weren't working. So it wasn't such a big sticking point that we thought it would be. And in fact, in some cultures, having a Friday off is probably a positive thing.
I think we have to look to the rest of the society that we live and work in, because about 80% of businesses of all sorts actually run 7-day services, and we can learn from them. But I would support what Jane said about it being up to local consultation and discussion, and it comes back to the example that Patrick gave of getting trainees to sort out their own rota. If you say to the group of staff that we would like you to run this as a 7-day service, how can you best do it within the rules? They will often come up with the best solution.
Thank you. I think that's a perfect place to stop, actually. So can we give a big round of applause to the panel?